Hello my friends, welcome back to Cardiac Academy. In the last video, we started our discussion on conduction blocks, more specifically AV blocks. So in this video, we're going to continue our theme on blocks, however, we're going to talk about bundle branch blocks. As always, we're going to take everything and break it down into simple, easy to follow steps. So let's get started. Alright, let's start talking about bundle branch blocks. So before we start talking about bundle branch blocks, we need to be aware there are bundle branches, right? So in the heart, you're gonna see that we have a right bundle and we also have a left bundle. In a future video, you're gonna see that the left bundle actually divides into an anterior fascicle and a posterior fascicle. But for now, we're just gonna concentrate on assessing for left bundle branch block versus right bundle branch block, okay? So as you can see, each of these bundles will individually depolarize one portion of the heart, okay? And the way we're gonna identify these is by two main ways. You're gonna notice that there's gonna be a prolongation of the QRS complex. It's gonna be widened. And additionally, there are gonna be some morphological changes that you're gonna be able to identify, okay? So let's start talking about the right bundle branch block, okay? So it's just like we said, the right bundle is going to be blocked, and because there is a block in one of the bundles, then the depolarization is going to take longer, okay? The depolarization actually has to almost wait until the left bundle has completely depolarized the heart, of the left ventricle I should say, before it starts going into the right bundle. So that's why you're going to see a wide QRS. So that's the first thing you're going to notice. The QRS complex is going to be more than 120 milliseconds, okay? That's the first step. And after that, you're going to look for a specific morphology, okay? So remember that V1 and V2 are right on top of the right portion of the heart. So that's where the first place you're going to look, okay? So with the right bundle branch block, we have a very specific type of morphology, often compared to rabbit ears or bunny ears, okay? And you can see that right here. So you're gonna see an R wave, and then an S wave, and then an R prime, okay? And these two R waves are compared to the rabbit ears. So the reason you're seeing this is just like we said, the right bundle is blocked. So the left bundle depolarizes first, and after the depolarization is almost complete, then it starts depolarizing the rest of the ventricle using something other than the right bundle. So it's very inefficient in doing so. So the QRS is going to widen, it's going to take longer. And then you're going to see the specific morphology, the bunny ears, okay? Additionally, you look at V6. And V6 is the left portion of the heart, right? Remember that the left leads are lead 1, AVL, V5, and V6. They see the left portion of the heart, okay? So as we see here, you're gonna see a wide S wave. You can see that right here. But the most important thing you should look for is for that positive deflection in V1 with a widened QRS complex, okay? The rabbit ears also help, but they're not always there, but it's good to look for them, okay? All right, so we can see here in this example, the first step is to look at the QRS complex to see whether it's widened or not. And we can see here that, in fact, yes, it is widened. You can see how it starts here all the way to here. That's more than 120 milliseconds. So yes, the QRS complex is prolonged. And then the next thing you look for is that morphology, the rabbit ears, okay? So you can see here how we have an R wave, an S wave, and an R prime. So those are the rabbit ears that we talked about. And also you're gonna see that it's positive. It's a positive deflection in V1. If you remember from our previous lectures, remember that the R wave progression starts more negative and becomes more positive as the wave of depolarization travels from V1 to V6. And you can see that here. So you see how it starts more negative than positive, and then as it progresses through the precordium, it becomes more positive. You can see that here. So in the right bundle branch block, you're gonna see it starts positive. You can see how this wave is mostly positive, okay? And that's another good way of remembering right bundle branch blocks, is that right bundles are upright, okay? Right bundles are upright. You're gonna see a positive deflection on right bundle branch blocks, okay? All right, and then we can also see that deep S wave and wide S wave on V6, okay, good. Then we shift into left bundle branch blocks. And in left bundle branch block, again, you're gonna see a widened QRS complex because the left bundle is blocked, so it has to wait for the right side of the heart to depolarize, so it starts depolarizing the left side. So it's gonna be a delay, it gets widened, okay? And again, there's gonna be a specific morphology you can look for. And this morphology is almost like a knife, okay? So you can see here in V1 how you have this deep S wave. It has like this knife morphology. That's the way I like to remember it. And then on V6, you have what is called the rook sign, okay? So the rook sign is like when you play chess, the tower, essentially. It will have this notch at the top of the R wave. You can see that right here. And it's gonna be positive, right? So we said right bundles are upright, while left bundles are negative, okay? You can see that here. Just remember the right bundle branch block is the bunny ears, the left bundle branch block is the knife, okay? That's gonna be probably the easiest way to tell them apart, okay? The rook sign is also something you can look for, but V1 is where the money is. Bunny ears, upright, right bundle, negative, knife, left bundle, okay. All right, we can see an example here. So we look at V1 and we see it's a widened QRS, just like we said. And then we see that knife, that negative deflection in V1. And then we can also look for the rook sign in V6. We see here. So we see the knife, negative deflection in V1. And then we see the rook sign in V5. All right, very good. Okay, another important thing to notice is that remember that any abnormal depolarization will give you an abnormal repolarization, okay? So it's completely expected to see T-wave inversion and ST depressions on both right bundle branch blocks and left bundle branch blocks, okay? Let's take a look here. So you see how these T-wave inversions, like we said on previous videos, is asymmetric, okay? Remember that when we talk about T-wave inversions in the setting of ischemia, it's gonna be symmetric. So if you do a mirror image, it's gonna look the same on the right side and on the left side. Now compare that to these ones right here. You can see that they're asymmetrical. They have a negative downsloping, and then they have a quick upstroke, okay? And if you do a mirror image, they look completely different. This is because they are secondary repolarization abnormalities, okay? So in the case of V1, you're gonna see those T-wave inversions and ST depressions on V5 and V6, because remember that V5 and V6 look at the left portion of the heart, and then V1 and V2, since they look at the right portion of the heart, that's where you're gonna see those T-wave inversions and ST depressions, just like you see here, okay? All right, good. All right, so what's the deal with the bundle branch blocks? Are they dangerous? Well, the best way to remember this is, are bunny rabbits dangerous? No. So unless it's like it has rabies or something, I don't know. So, but if you see a right bundle, you know, the rabbit ears, then they're usually non-pathological. In fact, if we did EKGs on random people on the street, you're gonna see a lot of right bundle branch blocks, okay? And these are usually non-pathologicals, okay? Now, in the other hand, a knife is always dangerous, right? So left bundles are always pathological, okay? So it could either be some issue with conduction, or it can also be like coronary artery disease, okay? Additionally, if you have a patient who comes to the hospital complaining of chest pain, and they have an old EKG, and it was like a normal sinus rhythm, no type of blocks, and all of a sudden in today's EKG you see a left bundle branch block, a new left bundle branch block, that is a STEMI equivalent, okay? All right. All right, enough drama. That last part might have been a little bit too much, but just let's summarize. So first, pro tip. If you have a prolonged QRS measuring more than 120 milliseconds, the first thing you're gonna do is look at V1. If it is upright, meaning positive, then you have a right bundle branch block. Just remember, right bundles are upright, okay? And you will also see that rabbit ears morphology. Now, if you look at V1 and you see a knife and negative deflection, then that's a left bundle branch block, okay? All right, let's do an EKG together. As always, let's follow our mnemonic. Let's be systematic. Remember, be systematic, not erratic. So erratic is our mnemonic. E is for EKG, and to make the mnemonic work, and then we have the first R, right? And the first R is for rate, okay? So how do we calculate rate? We have two methods. If you need a refresher on how to do that, I'll link down, I'll put the link in the description box below so you can refresh, okay, on that topic. But essentially, we need to first look to see whether the rhythm is regular or irregular. In this case, we see the rhythm is irregular, right? Because we see that the distance between QRS and QRS varies. So that means we need to use the second method, in which we count the number of QRSs and in the rhythm strip and then multiply by 6. Okay, so let's do that. We count 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And 10 multiplied by 6, 60. So 60 beats per minute. Then we have rhythm. And in rhythm, there are 5 questions, right? And I'm also gonna link in the description box below that video on rhythm, okay? So first, are there any P waves? Then, is there a P wave for every QRS? After that, is the QRS narrow or wide? Then is the rhythm regular or irregular? And finally, is the PR interval prolonged? Okay, so let's do that. So we look at for P waves, and we don't see P waves, we actually see fibrillation waves, right? So we have an irregular rhythm with fibrillation rate waves. So what kind of rhythm do we have here? We have AFib, right? And I'm gonna put in the description box below every single topic that is associated with today's themes, so you can refresh, okay? All right, so it's AFib, right? And following those 5 questions, so are there any P waves? No, we see fibrillation waves, and we identify this is AFib. Then we say, is the QRS complex narrow or wide? And we see it's a wide complex, right? And anytime we see a wide QRS complex, the next thing we do is look for bundle branch blocks, okay? And we do that by looking at V1. And in V1, if it is positive or upright, then it's a bundle branch block, right? So right bundles are upright. If it is negative, if we see a knife, then it's a left bundle, right? So when we look here, we see a knife, right? A negative deflection. And we also see the rook sign on V6, I'm sorry. So this is a left bundle branch block, okay? So for rhythm, we have AFib with a left bundle branch block, then axis, A is for axis, and we look at V1, at lead 1 and AVF. Both of them should be positive. Those are the 2 thumbs up, right? So we see that we have a positive deflection on lead 1, but a negative deflection on AVF. So that means we have a left axis deviation, okay? All right, then T is for QTC interval, and we don't want that T wave to be more than half in between QRS and QRS. And we look here, we have a T wave here, and we see that it's not more than 50% in between QRS and QRS, so it's normal, right? So normal. Then I is for ischemic changes, and on ischemic changes we look for T wave inversion, ST segment elevations or depressions, and Q waves as well, okay? So let's start by looking, following the left lateral leads first. So lead 1, AVL, V5, and V6. And here we actually see some T wave inversions, right? But let me just clean this up a little bit. Remember that we said that when you have an abnormal depolarization, you will see an abnormal repolarization. And that's exactly what we're seeing here. Since we have a bundle branch block, an abnormal depolarization, we see an abnormal repolarization. And we also said then that when we see inverse T waves, if they are due to ischemia, they're gonna be symmetrical, right? So if we do a mirror image, in the case of ischemia, it's gonna be symmetrical. However, in this case, it's asymmetrical. We see a downsloping and then a quick upstroke, okay? When we see that, we know this is most likely due to a secondary repolarization abnormality. And that's exactly what we're seeing here, okay? So we see it in lead 1, we see it in AVL, again, downslope and quick upstroke. We see it in V5 and V6, downslope and then quick upstroke. So we know these are secondary repolarization abnormalities due to the left bundle branch block, okay? All right, one thing to keep in mind, don't let yourself be fooled by this. This looks like a right bundle branch block morphology. Look at V1, okay? That's where it matters. Even if you see that morphology on the other leads, like in this case in V5, it doesn't matter. This is still a left bundle branch block, okay? All right, so for ischemic changes, we actually have none. And finally, C is for chambers. We look for hypertrophy, and we also have a video on that. So we're gonna look with, we have some criteria we need to look for. We have the Cornell criteria, and we have the Lyon-Sokolow criteria. And in this case, one of the easiest ways to quickly assess for that is on AVL. If the R wave measures more than 11 millimeters, that's positive. And in this case, we see that actually it does. So 5, 10, and one more here. So it's meeting just 11 millimeters. So we have actually evidence of left ventricular hypertrophy, okay? So in conclusion, we have a AFib with a rate of 60 beats per minute. We have a left bundle branch block. We have left axis deviation with left ventricular hypertrophy, okay? You see? Bulletproof. All right, good. All right, so we're only gonna dedicate 1 minute to this final topic. So often you're gonna see that the QRS complex is gonna be more than normal. It's gonna be more than 0.1 second. Remember that normal is from 0.08 to 0.1 second, but it's still gonna be less than 0.12 seconds or 120 milliseconds. So those are called non-specific intraventricular conduction delays, okay? And they're just gonna describe it often on the EKG. The machine is gonna read it that way. It has no pathological value, nothing to be too concerned about. And additionally to that, you're gonna see what is called an incomplete right bundle branch block. And essentially, all you're seeing is that on V1, you're gonna see that rabbit ear morphology, but the QRS complex is still gonna be less than 120 milliseconds, okay? And these are often caused by the same disease processes that can cause other conduction blocks, okay? All right, well, that's it, my friends. I hope that you found this video helpful. If you did, please remember to share, like, and subscribe. And as always, I'll see you back at the Cardiac Academy.